Good morning. I'm joined by Jessica Castro. I'm Tavian. We'll be talking to you about Zygopophyseal joint dysfunction. Some objectives: students will understand the principles and concepts about Zygopophyseal joint dysfunction. We will understand the cause of this dysfunction. We will discuss some clinical manifestation and functional limitations. We'll learn about tests and measurements to diagnose the dysfunction. Students will know about the differential diagnosis, and you will understand the elements and phases of the rehabilitation process.
So what is the zygopophyseal joint? It is also known as a facet joint or apophyseal joint. It is a synovial joint between the superior articular process of the vertebra and the inferior articular process of the vertebra above it, just like in the picture. There are two facet joints in each spinal motion segment, and they are situated between the pedicle and the lamina of the same vertebrae. They form the articular pillars that provide structural stability for the vertebral column as a whole. The term facet joint syndrome refers to the pain-provoking dysfunction of the facet joint. Is an articular disorder related to the facet joints and their interventions, and produces both local and radiating pain. As we get older, cartilage in our joints wears down. So an injury, repetitive movements, obesity, poor posture, and there's other spine conditions can change the way of our facet joints, how they move or how they're aligned. Changes in the facet joints can begin with the deterioration of a vertebral disc as the load of the body joint, of the body weight shifts to the facet joint. This pain results from the lesion to the joint and its pain-sensitive structures. Some clinical manifestations that we have with this condition, facet joint dysfunction can range from a dual ache to a chronic pain. So that may make it difficult for patients that have it to complete tasks on the daily living. We can have eggshell or lower back pain, stiffness or difficulty with certain movements, tenderness of a palpation, radiating pain locally or into the shoulders or lower back, stiffness along the spine in the lower back, burning nerve pain, muscle spasms, and muscle weakness as well.
So there are some functional limitations that come with this dysfunction. There will be some difficulty standing straight up or getting out of a chair. So as you can imagine, getting in and out of a car could be difficult. Any kind of twisting motion, so an occupation that requires unloading of boxes or turning, you will have some difficulty there. Flexibility will also be decreased. You have trouble walking upright. A lot of times this happens because the patient is trying to compensate to take some pressure off those joints. Or he would lean backwards to relieve some pressure. And reaching overhead will also cause some issues. Tests and measurements. I really want to highlight, so according to Dutton, the pain is presented when there is sustained head position, sudden backward bending, side bending, or rotation of the neck. Oftentimes we palpate the lateral midline to often show any changes of the soft tissue. And as far as the injection, so with this dysfunction, as you can imagine, there's other things that can occur that could be complicated to diagnose. So you want to apply a nerve block to isolate, to really try to see where the pain is coming from.
For differential diagnosis, we have sciatica, osteoarthritis, sacroiliac impingement, lumbar radiculopathy, myofascial pain, compression fracture, disc herniation, osteophytes, rheumatoid arthritis, and spinal stenosis as well.
I highlight according to Dutton. Also, I have the digital version. It's 1242 to 1243 in your Dutton book. But so as far as the rehabilitation process, it states that cryotherapy and electrotherapy does help with pain and inflammation. Some exercises, you want to do some isometric exercises, some core bracing, glute squeezes, some back extensions. You want to achieve some active range of motion. And then according to it speaks on the thoracic spine thrust, And that's the study by the Cleveland, the clinical prediction rule. There are 6 variables. Symptoms of less than 30 days, no symptoms distal to the shoulder, the fear avoidance belief questionnaire, a score less than 12, diminished upper thoracic spine kyphosis, cervical extension less than 30 degrees. If 3 of these are present, then the study showed a 54% to 86% improvement rate according to the outcomes. The intra-articular zygopophyseal joint, some injections in improve function with rehabilitation. So we just want to help the patient increase their flexibility, focus on their posture, make sure they're not compensating too much, either forward or backward. And then there are some surgical interventions if it is severe enough. And then radio frequency. So the overview. These joints are located in the posterior aspect of the spine that form between the lamina and the pedicle of the vertebrae. Dysfunction may be caused by aging and or stress on the joint. You may have difficulty standing upright and performing functional tasks. When testing, it is vital to reproduce the pain with movement. Range of motion, posture, and strengthening is going to be vital through the rehabilitation process.
Your reference. Any questions?
Any questions? So what is the purpose of the injection?
So for the injection, you want to, let me go to my notes. So it's a local anesthetic, and you want to inject it to the specific nerve that innervates the joint. This helps the doctor determine if the pain relief that follows the block is significant. If the pain is alleviated, it suggests that the facet joint is likely the source of the patient's symptoms.
Great job coming straight from the text. I could not have explained it any better. Typically, orthopedic surgeons or orthopedic medicine doctors, when patients have any type of pain, and they go complain about pain, what the orthopedic physician will do is give an injection. And so the injection is actually part of their assessment. You would think it's a treatment, but they want to assess the outcomes of the injection. So if the injection provides relief, then they have a clinical impression that, okay, it was some type of inflammatory process. And then they are further informed on what their next phase will be if the injection provides relief. But that basically we assume that it's a treatment, which it is, but they are also using it as an assessment. So good job.
Can you explain one more time what the traction superimposed?
The what?
On the rehab process, you had traction superimposed?
Oh, yeah, so basically it's just saying that it is, that is recommended. So you want to do traction.
Just give me an example. How would you differentiate facet joint entrapment or involvement? How would you differentiate that from spinal stenosis?
According to the article, we found there has been much has been written about the diagnosis and treatments, and about the lumbar or the lumbar facet joint syndrome and stuff like that. But there have been not much of the information out to differentiate a lot, because it says that most of them, they mimic a lot the pain as the same as the facet joint dysfunction, and it's gonna it makes difficult differentiate between those conditions.
That is true. Because it can be difficult to differentiate between lumbar radiculopathy and spinal stenosis, because both can refer pain down the lower extremities. And so now you have to incorporate your repeated movements along with special tests and maybe imaging as well. So now you have to have more information to have a conclusive clinical compression. All right, thank you all.